Good afternoon, colleagues, and welcome to this NHS England Allied Health Professions webinar. We're delighted to welcome you to the third in our 2026 webinar series that we are sharing with our AHP community this year. Today's webinar will showcase some key examples of innovative practice pathways across adult social care. These examples have also been picked as they highlight opportunities for future collaboration and how partnership working can lead to innovation. My name is Jamie Stamp, AHP Programme Lead for East of England Region in the NHS England Workforce Training and Education team, and I'll be introducing the session to you today. In order to do this, we have worked closely with our principal OTs across all regions and their principal OT networks to identify a range of fantastic speakers from both health and social care who will be sharing specific examples of good practice. We hope that this session will highlight the strength and value of partnership working and the importance of this for service user and patient pathways. Next slide, please, Rob. Before we start, I'm just going to run through a few housekeeping for the session. We'll be taking questions today via the Q&A function that can be found on the right-hand side of your screen. So if you have any questions as we go through the session, please do ask them and we'll endeavour to get our experts to respond to you. There won't be any opportunity to answer any questions verbally today due to the session being an hour, but please feel free to use the vote button to show us the importance of a question. We'll be asking for your thoughts and feedback at the end of the session today. There will be a short survey and QR code which we'd encourage you to complete to give us your thoughts and views on the session. If you experience any issues with viewing the slides, we would suggest that you log out and log back in again. Thank you. You will receive the slide deck and a certificate of attendance if you complete the survey. So I think that's all the technical elements covered. So if you can move on to the next slide, please. Just going to go through run through the aims of today's session. So we'll start by updating colleagues on national priorities for adult social care, showcase examples of innovative allied health profession workforce models and practices that are making a difference, to highlight the importance of AHP leadership across sectors in promoting opportunities for collaboration. And then we will then be encouraging you to think about next steps and how you can continue to build partnerships and to work on workforce optimisation service models and pathways to support the government 3 shifts and neighbourhood working. Thank you. I will now hand over to Catherine Greenlaw, Head of Practice and Assurance for Adult Care Services at Hertfordshire County Council, to provide some key updates for adult social care services. Thank you.
Thank you, Jamie, and good afternoon, everyone. Yes, so I'm Catherine Greenlaw. My substantive role is Head of Practice and Assurance with Hertfordshire Adult Care Services. I am an occupational therapist. I'm also co-chair of the National Principal Occupational Therapy Task Force, and it's as much in that role that I'm here today. Next slide, please, Rob. So in terms of the context and the drivers for allied health professionals in social care, there is an awful lot going on. Allied health professionals in social care, and certainly in local authorities, tend to be occupational therapists, but not exclusively. We have lots of different AHP professional colleagues helping us deliver social care in local authorities. We are, of course, led in social care by the Care Act 2014, a significant piece of legislation under which all of our activity is delivered. This emphasises the importance of well-being, prevention and enablement, aligns beautifully with occupational therapy, thinking, research-based. Bauman Christensen will say occupational therapy is not about health, but it's about well-being. The role of AHPs in local authorities delivering social care is very much about delivering our statutory responsibilities under the Care Act. So although we will have occupational therapists and other AHPs in specific teams perhaps, or delivering specific tasks. Actually, there's a more pervasive benefit to local authorities in having very active AHPs and occupational therapists in particular within that authority, and that links very much to the Allied Health Professional Strategy for England, AHPs into action, and strengthening the AHP community. Some of our other legal and statutory responsibilities are about eligibility, charging, safeguarding, rights and support for carers. Occupational therapists and AHPs more broadly can deliver and contribute to those areas of responsibility significantly. And one of the things about the Principal Occupational Therapy Network has been to highlight and amplify along, in line with the AHP strategy, the fact that AHPs can really contribute to the thinking, the practice, the development of strategy within local authorities. So we're doing all of that under the Care Act, but really kind of bringing that value of our professional skills. This means occupational therapists might be working in ways that may seem unusual to colleagues within the NHS, not necessarily something you would obviously think that we might be doing. And of course, you can get occupational therapists undertaking all sorts of roles, rather like myself in Hertfordshire. The Principal Occupational Therapy Network was really a network set up by I was previously the principal occupational therapist in Hertfordshire. My colleague, principal occupational therapist from Hertfordshire, is speaking today. We came together as a network to really make the voice of occupational therapy in local authorities much louder. Unlike in the NHS, there are two main regulated professions in local authorities, and then in social care more broadly there's the third. So there's social work, there's occupational therapy, and then there's nursing, and then, as I said, there's AHPs threaded throughout. And social workers, they have a chief social worker. We have a chief allied health professional, but sitting in the Department of Health. So those conversations with government about what's going on in local authorities and local government were not necessarily representing the voice of occupational therapy. The value of occupational therapy wasn't necessarily seen by directors of social care. So the network has come together. We've made huge progress. We've got a much higher profile. We work very closely with the Royal College of Occupational Therapy, and we're getting to be someone in the room, which is really important, because I think, as with the AHP strategy, AHPs can really deliver for people, and we can deliver within local authorities. So a significant event at the moment is the Casey Commission. Baroness Casey has been asked by the government to review social care. That's all of social care, local authorities and provider services. Anita Mottram, who's the other co-chair of the National Task Force for Principal Occupational Therapists, and I separately were able to go along to present evidence to the Casey Commission, and our previous chair, Caroline Haig, was able to go along with Suzanne Rastrick, who's Chief Allied Health Professional, to give evidence as well. We're also having individual meetings with the Casey Commission, really important to engage with the Commission. So we've been doing a lot of work in local authorities to get AHPs and occupational therapists to contribute evidence. And I put the link in the slide there. Contact us, the Casey Commission, because actually the wider AHP community will have something to say about social care, and that's your opportunity to contribute. And for me, there's two benefits. The voice of AHPs needs to be heard within that commission, and they need to see that AHPs have something to say. Other pieces of work and other context for local authorities is CQC assessments. Local authorities haven't been assessed formally by an external provider for some years. CQC assessments were reintroduced by Health and Social Care Act 2022. They've been very useful for actually illuminating the value of AHPs and occupational therapists within local authorities, and in their iterating assessment frameworks, they are looking for leadership from occupational therapists within a local authority, without which they do not understand how that local authority can deliver prevention and enablement. The NHS 10-year plan is talking about better integration of working, a shift to the community, integrated neighbourhoods teams. And I've always taken the view that social care and primary care in the community are just same bit of the circle touching from a slightly different direction. So there's lots of opportunities for us to work with our primary and community healthcare colleagues. I've touched on the AHP professional strategy. The other thing I just put in terms of legislation is the Housing Grants and Regeneration Act. That's the act that allows for the disabled facilities grants. A lot of work done by local authority occupational therapists in the area of housing and adaptations, which we all know is absolutely transformational for people. I'll stop there and I'll pass on to the next speaker, or back to you, Jamie. Thank you.
Thank you so much, Catherine, for those updates and your insights into the structures within social care. Thank you. I'm now really pleased to introduce our first two speakers, Caroline Robinson and Gracie Moore, who are both senior occupational therapists at Essex County Council. Thank you both.
Thank you very much, Jamie, and good afternoon, everyone. As Jamie has just said, my name's Caroline Robinson and I'm joined by my colleague Gracie Moore, and we are both senior occupational therapists in adult social care at Essex County Council. Today we're delighted to be talking to you about our learning of the sensory systems and how this can impact manual handling. Next slide, please.
Thanks, Caroline. So our ability to move, focus and participate relies on the brain and body organising information from our senses. This is the process of sensory integration. We have 8 senses: touch, smell, taste, hearing and sight, and 3 less commonly known senses of proprioception, vestibular and interoception. Due to the time constraints today, we won't cover this in a lot of detail, but we have provided a link to a free online training at the end of this PowerPoint, and I believe it's also going in the Q&A as well, if you'd like to utilise that to find more. A useful way to understand sensory integration is to imagine the brain as a conductor of a large orchestra. Your 8 senses is like instruments playing at the same time. The conductor is continually balancing, timing and coordinating them to create a smooth performance. Now, when this works well, we can stay upright, concentrate, respond to what's around us and feel comfortable in our environment. But if some of the instruments are too loud, too quiet, or they're out of sync, then the whole piece becomes disorganized. In the same way, when sensory information is overwhelming or poorly regulated, everyday tasks can feel confusing, effortful, or unsafe. Next slide, please. Prior to 2021, sensory integration was largely viewed as a health-specific need, and it wasn't widely recognised within Essex adult social care. Since then, our understanding and the application of sensory integration has grown significantly. From 2021 onwards, we began developing an organisational-wide approach, moving from limited awareness to increasingly aiming to embed sensory integration in everyday practice. In 2022, the organisation invested in post-professional training in sensory integration for a small group of OTs. These OTs have delivered workshops and CPD sessions to the wider workforce, encouraging curiosity in recognising sensory needs, preferences and differences. Our provider quality team has also taken this forward by incorporating sensory considerations into CPD sessions for domiciliary and residential care providers. This collective learning has helped our workforce recognise how sensory needs influence participation, well-being and engagement in activities of daily living. From here, a small group of OTs with a special interest came together to explore the impact of sensory integration on moving and handling practice. Myself, my co-presenter Caroline, and our colleagues Caris Cartwright and Isabel Verling carried out a deep dive into available resources, training and approaches. We brought together our findings into a workshop and an article shared across the organisation, which led us to share this work within this forum today. To give an example of how sensory integration is relevant to manual handling practice, consider the task of being supported to transfer to a shower chair using a rotunda. During this activity, the tactile system helps the person register and tolerate the touch from a carer and feel the surfaces of the rotunda, guiding safe hand placement and foot position. The vestibular system supports balance and postural control. The proprioceptive system provides awareness of body position, helping the person judge how much effort to use when standing and when sitting. And together, these sensory systems help the brain organise the movement sequence, stay stable during rotation, and feel secure throughout the transfer. Next slide, please.
So it has been found that trauma profoundly impacts how the brain processes and responds to sensation. When someone experiences trauma, especially early or repeated, it can lead to sensory regulation difficulties where the brain either over-responds or under-responds to sensory information. When active, it's often referred to as hypervigilance, which is a survival response where the nervous system is constantly scanning for danger. And in this state, sensory input like noise, touch, or movement can feel exaggerated or threatening. Feel painful, or a sudden sound might trigger a fight, flight, or freeze response. If you've ever been in a situation that's made you feel uncomfortable or on edge, your heartbeat might quicken, your breathing might become shallow, a rush of blood to your muscles may cause you to sweat, and you may feel an overwhelming sense of anger. And could be your brain's survival response being triggered and may result in you feeling the need to fight off the threat to keep yourself safe. In manual handling, people are often quickly labelled as being aggressive or challenging, potentially through exhibiting behaviours such as hitting carers when being told, or pushing carers away when they're fitting slings, for example. However, with a trauma-informed and sensory lens applied, their nervous system was more likely trying to protect them from the danger it perceived from these activities, placing them into a hypervigilant state due to their past trauma being re-triggered. And in this state, even small sensory information can tip, flight, or freeze. Next slide, please. Can we move the slide on, please?
It has moved on from our...
Thank you. So this is Alfred. He is a fictitious character created through aspects of real life case stories. Alfred has vascular dementia and lived in the war and was a known survivor of a prisoner of war camp. Alfred's bed is positioned at the far end of the room with his back to the door, as if it enabled him to look out the window. Alfred would hit out at carers during the morning routine when they rolled him to fit his sling ready for hoisting, and this gave him the label of exhibiting challenging behaviour. The social care occupational therapist identified that despite carers knocking before they entered Alfred's room, he was not able to hear them as he hadn't got his hearing aids in at that point in the day, and as he couldn't see them coming in, he was surprised by them appearing at his bedside. This was re-triggering of his past trauma and resulted in his brain being in a hypervigilant stress state. And additionally, Alfred was up when his vestibular system, so by altering the layout of his bedroom to still enable a view from the window and also a view from the door, meant that Alfred was aware when the carers were coming into his room and not surprised by their touch. And also by enabling other routines to take place first, such as medication and breakfast, Alfred's vestibular system was woken up and ready for the movement. And so overall, this resulted in a much calmer response from Alfred. Next slide, please.
Along our journey, we've identified a number of practical sensory-informed considerations that can support safer, calmer, and more collaborative manual handling. Now, these are not blanket approaches and one size does not fit all, so sensory needs will vary widely between individuals. So that means any strategy needs to be trialled, adapted and personalised based on the person's preferences, their responses and their overall presentation. So firstly, learn the adult's sensory preferences. If someone does appear distressed during manual handling activities, then meaningful use of preferred scents, sounds, touch or textures could support regulation and reduce anxiety for some individuals. Before supporting a transfer, consider the person's alertness and their readiness for movement. Some people might benefit from a gradual, predictable lead into movement to gently prepare them before completing a transfer, especially if they've been sedentary for a long time. Using tactile or visual cues such as stop and go cards can help communicate when the movement will begin or end, or tapping the body part of the person when they need to move if they become overwhelmed by verbal instructions. If appropriate, these cues can increase predictability, support understanding, and can enhance a person's sense of control. Check the visual field to ensure that the person's view is not obstructed by the hoist spreader bars, sling straps, or other equipment. Limited visual input increases the demand on the vestibular system and could make movement feel more challenging. Reduce the swing of the hoist by applying deep pressure touch on the person's back to minimize swing, providing that they can tolerate this type of input and someone standing behind them out of view. When moving a mobile hoist, perhaps lowering the person so their feet can gently rest on the hoist base can offer a grounding and more improved stability. And lastly, consider the sling material texture or fit. It could be uncomfortable for the person. Exploring alternatives where safe and feasible and observing their response could help identify a better match. Next slide, please.
So here's how you can find out more information about sensory awareness, and we've also included our contact details if you'd like to contact us at all. Your questions will be welcome. And next slide, please. So thank you very much for listening, and I will hand back to Jamie.
Thank you so much, Gracie and Caroline. So important to understand the impact of the sensory system when using manual handling techniques, and clearly something that everyone needs to be aware of across. So thank you. Our next speaker is Laura Owers, Principal Occupational Therapist for Adult Care Services at Hertfordshire County Council. Thank you, Laura.
Thank you, Jamie, and good afternoon, everyone. So, yep, I'm Laura Owens, Principal Occupational Therapist with Hertfordshire County Council. And so I'm going to talk you through a piece of work that I led around an integrated system-wide approach to our response to bed safety and the 2023 MHRA Safety Alert Response. Next slide, please. Okay, so a little bit of context just to kind of set the scene. So the MHRA, Medicines and Healthcare Products Regulatory Agency, issue periodic alerts. And we had an alert in 2023, which was focused on items of equipment solutions where there is a risk of entrapment, particularly around profiling beds, and accessories, so bed rails, bed grab handles, and similar solutions, trolleys, lateral turning devices. So this was around our system-wide response, but some details on the slide there, which will give you more details about the original alert that we were responding to. Next slide, please. I'm not sure if that's quite catching up for me. Has it gone to the next slide?
I think it's on its way.
No worries. All right, so at the time there were specific requirements that we needed to work towards, that the alert had set out. So this is just a bit of an overview around what the requirements were. So what the MHRA and the particular alert was asking us to do was to look at updating our relevant policies, procedures and practice guidance around the provision of those bed solutions, training for all applicable staff, so with regular updates. There was a requirement or a set of requirements specific to equipment service, so that was around the provision of the equipment. There was a requirement to complete reviews, and that was a particular focus for this particular alert. There have been historic alerts around bed rails, and this was particularly a key feature of this latest one. And so ensuring updated risk assessments were in place, and that they were updated when any circumstances changed, and that we were identifying that with those regular reviews, and also that people at highest risk were prioritised. And there were some additional guidance this time round around what MHRA would speak to as atypical anatomy. So again, recognising people that were at highest risk as a result of specific anatomy considerations. Next slide, please. So what we decided, and this was through my involvement with our Herts and West Essex Integrated Care System and our Allied Health Professions Council, what we decided is that we would have a task and finish group, which was a group that I led. And that we would take a system-wide approach in terms of our response to the alert. So the membership was, as said, was around Herts and West Essex Integrated Care System, and this was specific to, or the scope of the group was specific to those of us within the system who had a role in assessment and prescription of those equipment solutions. So it was really around the assessment aspect. Terms of reference were that membership had been identified by the AHP Council so that we could make sure that everybody across the system was represented. So we had those links with the council and the organisational leads. It was chaired by myself, but very much a collaborative effort, and that we reported back into the AHP Council with regular updates. So there was a level of governance there and an opportunity to make sure that the broader messages were circulated as needed. And so our objective was around agreeing a consistent system-wide approach to that practice in response to the alert, but an opportunity for us to ensure that we did have consistent practice around bed safety, around ensuring kind of a person-centred approach to assessing for and providing those solutions where they're needed. All right, next slide, please. So just to give us a sense of where we were at, what our starting point was in terms of our system. So there'd been a bit of a drift in practice. So there'd been a previous alert in 2018, and we had at the time adopted a system-wide approach with a bed rails policy that was kind of adopted across the system, and certainly within Hertfordshire. And we were at a point where certainly many things had happened, including COVID, and practice was no longer consistent with that original policy. Services had changed, had evolved, and had generally adopted their own local policies and approach. So that was the starting point. In terms of cross-system coordination, of course, we were trying to coordinate an approach across many organisations, diverse scope of services, acute, mental health, community, social care. List goes on, not an exhaustive list. We had a time pressure, and there was a specific time frame within the alert that we needed to work towards, and so we were conscious of needing to work within that time frame. And for me, there was something around, there's always a concern that if you have an alert that highlights the level of risk, which we were aware of anyway, that there is the possibility of moving towards a potentially risk-adverse approach to practice, a more amplified perception of the risk, and possibly a reluctance to, or an avoidant approach for certain solutions, and keen to make sure that we were still taking a person-centred approach and providing the right solution for the person at the right time. So there's something around kind of standardisation versus individual service needs, so balancing that within our approach. There's also a kind of quite a wide variety in terms of the range of equipment across the community, mix, legacy, stock, etc. So something we need to be mindful of, and absolutely a variation in prescribers in terms of their confidence, their knowledge and skills, not least scope of role, but also around that kind of confidence and around their understanding of the entrapment risks. Next slide, please. So the approach we took with all of that in mind is that we would agree a set of broad bed safety practice principles. So rather than having a a wide policy. We learned from the previous approach that it's tricky for services to kind of maintain that. And as I say, there had been a drift with services evolving over time. So we decided that what we would do is that we'd have this clear system-wide commitment to a kind of broad set of principles. We'd set out how we intended to work. It would be consistent with the MHRA requirements and broadly consistent with our sort of commitment to be person-centred in our approach to risk and how we wanted to work with people. So you'll see on the screen, rather than listing them, but a broad range of principles that speak to enabling choice and independence, recognising the individual, being mindful of scope and competency and the range of services, and that it would be strengths-based. And so that we would kind of get the right solution. We would get it right in terms of what was relevant to that particular set of circumstances. And there was something around being more confident around being able to balance the risk factors that were present to identify the right solution. And then in addition, there's of course something around our partnership working and how we kind of strengthen and improve those pathways to ensure we can work in a way that's consistent with the principles and that we're clearly communicating information to the people that we work with, the families and our partners. Next slide, please. So in terms of how this was implemented, we took an approach whereby each task and finish group member was tasked with embedding those principles within their organisation. So that was partly about making sure that we had the right representation to start with, and those links through the AHP Council ensured that. And that way they could ensure that it aligned with any existing policy and existing governance, and that we had a sort of overarching oversight through the task and finish group and through the AHP Council. We had a system-wide learning offer, and that's ongoing. So a series of bed safety webinars that were delivered by myself and via our Hertfordshire Equipment Service, occupational therapy lead. And so that was around shared practice, shared understanding of that sort of person-centered approach, confidence around considering risks and balancing, considering those risks on balance and being able to identify the right solution, and having that shared understanding of the broad range of equipment solutions and their compatibility with each other, which can be a challenge. There are many. So that's ongoing, and we've just delivered an updated version. It's available as a recorded resource. So part of this has been around having a clear review and referral process. So from a social care perspective, we have a clear policy in place that sort of details how we undertake our own scheduled reviews within adult social care. And so part of this was around health partners understanding the scope of our approach to reviews, how to refer into our service. And that's part of that, about ensuring that those pathways are consistent and that we're identifying when equipment is in the community and is required to be reviewed. We presented this to our Herts and West Essex ICS system quality group to ensure again that we were able to kind of cascade those messages widely. And then we took an approach whereby that task and finish group that had agreed those principles would then have a role to embed them. And so we looked at kind of specific areas to ensure that we were able to strengthen our practice, to strengthen our pathways, and to ensure that we were actually able to work alongside those principles. So the starting point was the principles, and then there's been that ongoing work to embed them. So you'll see here a range of areas that we identified that we knew were challenging and that we needed to kind of strengthen around sort of consistent messaging, partnership working, and the practice and the ordering process. Next slide, please. So just in terms of kind of what next and sort of key reflections from that work. So in terms of what next, what we've established is we're not meeting regularly as a group. We've kind of done that initial implementation. And so now what we have is sort of maintaining that sort of proactive system-wide approach to monitoring the practice within our own organisations. And that task and finish group has really kind of evolved into a network that allows us to kind of make quite timely contact with each other whenever we identify any issues. And I've got an example on the next slide to kind of leave with you that gives an idea of how that's working in practice. And it is working, you know, because we've formed those relationships and we've got that shared commitment to how we intend to work. It supported us to do that. So the impact of the group in terms of reflections that it has been able to strengthen partnership working, of course, specific to bed safety practice, but beyond that, in terms of the pathways that this relates to, it has kind of more broadly strengthened some of that working, particularly around kind of referrals, etc. And so it's given us an open space for learning and for sharing that best practice. Certainly, some of the approaches that we've individually adopted in health services have been shared by others, and so it's been a really valuable piece of work. In terms of sort of key reflection, probably not surprising, is recognising that in order to embed that consistent practice across what is a large system, it does take time, and it is an ongoing proactive effort. It's still ongoing. You know, we're in a good place, but it requires us, as mentioned, to really continue to monitor that and ensure that we continue to work and in a way that is aligned to that kind of fundamental focus on the person and to maintain those relationships. Next slide, please. So this is really just a case of sort of leaving with you rather than going through, but it is a piece of work that's come up recently, and it does illustrate how that task and finish group has evolved into a kind of ongoing forum and allows us to kind of really respond to some of the issues that arise in a really sort of prompt and timely way. So just to kind of give you a bit of an example or a case study in practice about how we're working now. Next slide, please. That's me, just to say thank you very much for listening, and I'll hand you back to Jamie.
Thank you, Laura. Great example of cross-organisational working and system working, and that continues, and you've obviously got these structures to continue to go back to if needed. So thank you. I'm pleased to introduce our next speaker. So it's Alex Hedaya, Head of AHPs, Tower Hamlets and Newham, with ELFT, East London Foundation Trust. Thank you, Alex.
Hi. Thank you, Jamie. Hello, good afternoon, everybody. My name's Alex Hedaya. I am now the professional lead for 4 professions in Tower Hamlets and Newham Community Health Service in East London, and I look after the POPs professions. That's physio, OT, podiatry and speech therapy. But today I'm really talking about a piece of work that I did when I was in my previous role almost a year ago now, and I was principal occupational therapist in Tower Hamlets Council. And I don't know where colleagues from Tower Hamlets on the call. Thank you for coming along and your support today. That's brilliant. But there's also colleagues from other areas across the country that would have heard these slides before. So I'm sorry that it may well be a repeat for some of you, but I hope that you appreciate the sentiment of this work. We want to carry on presenting it as business as usual. So it's really getting the opportunity to share the work that we've done and how we've gone about it. So without further ado, next slide, please. So our problem really is thinking about in North East London ICB, there are approximately 284 patients staying in hospital who basically don't meet the criteria to reside anymore. And that means that that equates to 10 to 12 wards of patients at any one time across our ICB, which is only 7 boroughs and quite small, to about £44 million a year. And I think that is probably the biggest figure I can leave you with today. And that £4 million is a huge amount of cost pressure on our system. And how can we as allied health professions do something about that? Catherine spoke at the very beginning about how allied health professions I have a chance to say about adding value. Actually, I think this is about we needing to shift the narrative even further along. It's that we do add value, and this is how we contribute to changing the value added impact of all of our allied health profession colleagues across England, Wales, Scotland and Northern Ireland. So we were thinking about the impact on patient care, and I'm sorry the slide looks really, really small, but I hope that we will send out the slides further afterwards so you can see them in more detail. But for now, we're thinking about the impact on patient care. If you're in hospital for too long, as you all know, that leads to deterioration in all areas of someone's life. And it also means that increased risk of hospital-acquired infections and start to lose really rapidly loss of independence and it's quite significant. And there's various pieces of research published that identify all of that. So I won't go into detail now. And if we work backwards across the acute system, if you think about if we can't get people out, how you can't get people into theatres, into rehab, into those acute settings, into A&E, out of those ambulances, if you don't have an ambulance stack, how do you manage that flow of patients from the community into the hospital where people really need to have that intensive care, if you like, or they're not being on an intensive care ward, and back out into the community again? So it really impacts on that whole system. And then the financial costs are just huge, aren't they? Often we're finding that capacity issue is in the community. So I think this is really good evidence for us to be thinking about the left shift agenda and how we will be thinking about acute community and that sickness to prevention schemes or the thinking of all of our work in the future. And I really believe that occupational therapy and social care has got such a huge role to play in that prevention agenda and how we prevent people being admitted to hospital, but for preventing them from getting sick in the first place and how they have that more ownership of their own care in the future. So it all spins into this work. Next slide, please. So we talked about hospital-acquired disability when we were meeting and had our working group thinking about how we discharge patients with a more optimised care handling. And we are really talking about how do we discharge patients in a way that means that they are getting the right size care package while meeting those rehab needs at the same time. And this slide shows all of those hospital-acquired facts about muscle mass and about how people are then facing all sorts of impacts because of all of those hospital-acquired issues. So really looking about how can we even shorter length of stay for those individuals by 1 or 2 days starts to impact muscle mass loss. So if we can get people home faster by right sizing care packages in this theme, then we are having such a massive impact on our patient group or residents that we're looking after. But ideally within the social care professions and that setting, we're stopping those people even getting to that point because we've managed it in the community. So our project on the next slide, please. We wanted to think about how would we have an improvement in our quality of care interaction. So we really wanted to think about what are we trying to deliver here? Are we thinking about the person in that hospital bed or in that chair in their living room, in their microenvironment? What's life like for them as that person receiving that care? So if we had a better setup of care provision, could the person being cared for in their own home be included in their care more than they have been in first? If you ever get a chance, get hoisted, have a go in it. It's really quite intimidating when people are talking about you or not even with you or to you. They're just talking about something else and you're being done to while you're in that hoist sling. It is really not a pleasant experience. But if we can improve how that might feel, can we think about what carers we are delivering and in the way we are delivering it? We really wanted to think about maximising that independence, which I've talked about before, and then preventing that deconditioning in the first place. So this is going to become our conversation of the future in much greater detail. As I've said, we want to really think about reducing the length of stay and then how to improve that delayed transfer of care. So actually, if we're working with our system colleagues, I would really think that we could be speeding up the time in which we can deliver those services because we built trust in our system. And we're really thinking then, how can we, across that system, reduce the care costs and that burden on the public purse in a more wider sense, that we can really make sure that if we can have an improved flow, that those people are really having the care where they need it at the right time. Next slide, please. So thank you. So a slight delay in the slide loading there. So the pilot outlined in Tower Hamlets, we got an opportunity via the Better Care Fund when there was money, she says, to do a bit of an elevator pitch to get some money for an external case, or a consultancy company to support us with a piece of work to review optimal handed care in Tower Hamlets and how we can embed this piece of work as business as usual with some evidence to support that work. And we collected, having had various workshops and thinking together on almost a weekly basis with this external company. So it's Health Integration Partners who kindly put together these slides. And I believe that Deb's on the call today. So thank you to colleagues there for helping us put all of this together. We collected data for 12 weeks already. I can't believe it was getting on for 18 months ago now, between October and January last year across 2 of the elderly wards in the Royal London Hospital. And that was about complex care. And we tried to pick the most comprehensive, complicated possible patients we ever could. Because if we get those right, we can get all the others right. And we looked at how we would be managing those individuals across the care pathway. Next slide, please. So within our pilot, we looked at manual handling practices and what we would be doing, making sure that we would be using the right equipment. When we talk about that, we're trying to encourage that patients who are sitting in a hospital bed do suffer rather a lot from having a white coat syndrome, and doctors, the medics, the nurses, the therapists on the ward can be known to say to patients, and I'm sure you'll hear this story across all of the work you do across the country, that you'll go home with double-handed care 4 times a day. And that's really the cultural message that we're trying to get rid of, and to try and make sure that we're saying you're going to go home with the right care and equipment for you. And that might be 1 or 2 carers, or you might go home with 2 carers initially, and then we will review that really quickly from our social care colleagues. And then we will think about making sure that you're as independent as you possibly can, so that we're really thinking that you're not having to have too many people appear in your house every day, waiting for that second carer to turn up. And working in East London, we suffer from lots of traffic, I'm sure you can imagine. And although it would be really lovely to have people walking everywhere, sometimes it's just not possible. So trying to make sure that people can be delivered care in a really timely way. If that's through one person that individual gets to know really well, you really start to form really close links, and you can deliver that care and that compassionate, holistic way as much as possible. It really becomes quite exciting. And it's really, for us, very much part of our work was thinking about how do we make sure that becomes a system-wide piece of work. So our objectives on the next slide, please, through Health Integration Partners were to think about the delivery and evaluation of the project, and making sure that we learn from this and how we build an evidence base for decision making from this pilot. So we had a really robust design process that included more data impact assessments than I ever care to do ever again in my life. And I did 3 for all of the organisations where we were collecting data from. So it did take a while, but don't be put off by it. Everybody was super helpful, and we were able to get the data that enabled us to track patients through the system, both as part of the evaluation work and also prior to the evaluation. So we were able to have a cohort of individuals that were not included in the work to be able to measure it against in a proper old pilot way to really evaluate it. We made sure that we were doing that pilot in a very set timescale, and we wanted to stick to that. So while the timescale wasn't great covering the Christmas and New Year period, it meant that we were really holding ourselves to time and task to make sure we delivered that. We wanted to make sure we had some really high quality data. I think more and more we're hearing about how we deliver occupational therapy, physiotherapy across our systems. How do we ensure we are an essential provision of services to these individuals now as part of the left shift agenda? So if I am doing this well, we should be making sure that we are sharing this in webinars such as this, thinking about publishing pieces of work. How do we make sure that we are there and evidence-based to support our professional development? So we wanted to share this about the wider system work as well. And then making sure that the methodology is really rigorous enough. So we did make sure that we were thinking about all the pieces of previous research on that were done. Next slide, please.
Sorry to interrupt, Alex. We've probably got a few seconds now before we need to hand over to the next speaker.
Okay,
Thank you.
so if I want to skip forward a couple of slides, then let's go to the findings. So the findings slide, we basically found that using the CFS Rockwood scale to enable us to measure care impact across the system has been super helpful, that we've reduced the length of stay for pilot patients on the evaluation, and that's been done and completed. And then there's a really nice stat there for you that if we could think about this, for 30% of our cohort being discharged out of hospital with this optimal handed care package, we would be saving £200,000 per year on care package provision. So if we were to scale that up, it starts to speak for itself about the impact of that across the system. You can put up the conclusion slide if you like next, please. And then we were thinking about how all of those costs have been managed and limited, and how we might manage that. And this will hopefully come out in the slide pack so you can read it for yourselves. But at the moment, our next steps on the next slide mean that we are thinking about having this managed as a quality improvement piece of work, how we are ensuring that there's a patient involved in that quality improvement piece of work that Barts Health are now owning, rather than it being sat in the community. It's really thinking about how Barts can embed that in the acute setting. So we still start to make sure that we are holding that robustly there. And now I'm working in a different role. So I'm working as the AHP lead in 2 boroughs in health now for East London Foundation Trust. I'm able to start embedding this within the Newham system. So we are now we've got a Newham AHP steering group, which is new and up and running. And this is one of our agenda items to think about that hospital flow and discharge impact. So we are trying, by changing the Barts Health manual handling policy across their 4 hospital sites, to gradually work through all the hospital settings in North East London for that same trust, to think about the impact of optimal handed care.
Thank you, Alex. I'm going to have to move to our next speaker. Final slide will be shared, so thank you so much. I'm going to move us on to our next speaker. Okay. Yeah. Okay, so thank you. I'm really pleased to introduce our final speaker, Melanie Furness, Moving with Dignity Team Manager and Nurse with Norfolk County Council. Thank you very much, Mel.
Okay, thank you very much, Jamie. As introduced, I am a Queen's nurse working for Norfolk County Council and have been in post for 22 years. Next slide, please. Okay. So many organisations will use the terms optimising care, single assist care, proportionate care. It really doesn't matter what each organisation use. We chose to use in Norfolk optimised approach to moving and handling because we feel that optimising is very much a person-centred approach. We wanted to put the person first. We wanted to make the assessment around the person, but also we know that it's not a perfect world out there, so we wanted to utilise the equipment and also look at the environment that we're working in. We know often that patients' homes are not as perfect as we would like, so we obviously have to make the best practical use of that situation. And also we wanted to draw away from sort of everything being single-handed care. We could have some clients or patients, for example, that might have 4 carers, for example. We're needing to reduce down to 2 carers. So this approach has worked really well for the last 4 years. Next slide, please. In 2023, the local ICB, Norfolk and Waveney, offered some funding into my team to look at supporting an optimised care project across our acute hospitals and community care. So what I did is the first phase was exploration. What was the barriers? What were the differences? We have 3 acute hospitals in Norfolk, 1 in the Central Belt, 1 in East and 1 in West. What I identified was, do we actually follow employ the same systems in equipment provision. We are aware about NHS prescribing, and their equipment within the acute hospitals is very different to what we supply within the community environment. Was there a different approach to moving and handling training, acute versus community? Absolutely. There are different themes in the acute hospitals that have to be addressed, clinical governance versus what we do within the community. So there were some differences in practice. We also identified, was there any prescription of care packages? Yes, there was. We were working with clinicians, both OTs and nurses, that have said, yes, we've always discharged with tea, we need to always do it with tea. So was it a risk adverse culture? We picked up that, yes, it's always been done this way. We're really too scared to reduce to one. We also noticed about changing ward behaviours. As a nurse myself, what we found is that we nurses very much, we do things about task specific, and what we found is that nurses were reluctant because they were very busy about taking ward therapy recommendations. It's really difficult. They're saying we actually don't have time to implement that therapy advice, and as established, there was a lack of knowledge about equipment that we prescribe within the community environment. Next slide, please. So phase 2 was around education. So what we wanted to do was actually develop an e-learning tool for equipment prescribers. So when we mean by equipment prescribers, we mean everybody working in the acute. So primarily occupational therapy leads and occupational therapists working on the ward and physiotherapies. We wanted to focus with our transformation locally around self-care prevention and single assist approaches, really encompassing what the patients to get active and involved within their own care. The e-learning was added onto the Acute Trust, ESR and learning development platforms, and there is a link to our manual handling YouTube for the videos. We then decided to do therapy lead training, so we went into 2 of the 3 acute hospitals at the moment, so the Queen Elizabeth in Kings Lynn and the James Paget in Great Yarmouth, where we actually focused on social care model of training. We also wanted to involve the Moving with Dignity leads. They're the ones that are going to be championing the training further forward and actually try and get them to use this as normal language within an acute hospital as well, so that everyone is saying the same message. I call this the bottom-up approach. We look at the train the trainer, of course, for independent sectors. So it's a bit like a sandwich. We've got the top-down working with the bottom-up approach. So we devised a 3-day train the trainer course for trainers working in the independent sector. For me, training is not about in the classroom. We would like to work with the patients within their own homes. We've seen an increase in complexity. So we like to look at the equipment within their own home. How does it work with the carer? How does it work with the clients? We actually recruited somebody to go and deliver some support locally as well. Next slide, please. So the phase 3 was about working with the therapy assessments on the ward. What we found was that the discharge hubs were making their own decisions. That was led by nursing staff. What we now actually say to any sort of complex or discharge, go and involve your therapy leads, actually get the therapy working with the patient on the ward, and before we start planning that discharge. Queen Elizabeth Hospital been really proactive. They actually purchased all of the equipment that we use within the community environment to try with patients on the ward. In a risk-safe culture and environment, we are now encouraging and supporting the use and trials of complex equipment with the patient in the hospital. So, for example, we'll get specialist ventilator systems to use on the ward. Don't wait until the person is discharged where there's less hands available, less skill sets available. And we're also encouraging and supporting care providers to meet with patients whilst they're in hospital. So I've often been up there on the wards, working with the therapist, working with the hospital staff and the independent sector to get that person, the carers, confident with the patient, training and use of the equipment. Next slide, please. So we can see with our results for our 2024-2025, and that was with a reduced team. We didn't have a full team. We actually looked at actual cost savings of 474,000, just over. And we also look at prevented cost savings. So actually put our interventions preventing a cost of a care package in the first place. But we're also capturing the use of equipment cost at early intervention. So is it the right request that's coming through? So often we'll be asked for chair beds, for example. Actually, is it the right equipment? So involving a Moving with Dignity team, we've actually been able to save some money on the equipment prescriptions as well. We also work across borders with Suffolk County Council as well. So we have linked them into our training model as well, working with their principal lead therapist. Since this presentation is done, our figures for 2025 to 2026, we actually had actual cost savings of £700,000. Next slide. So I'd like to say thank you very much for inviting me to present at this webinar, and if you require further information, there is our contact details.
Thank you so much, Melanie. Really interesting. So thank you. Can I just ask, was there any, did you find with the changes to, I suppose, equipment provision and the way it's allocated, do you find any sort of reluctance to change around that? I'm an occupational therapist, used to work in the acute trust. Did you find any sort of reluctance to change around the approach?
Our occupational therapists across the community and acute sectors have been really proactive and really keen to learn and change. They recognise a shortage of workforce and that we do need to change practices. So it's actually been very positively received.
Brilliant. Thank you very much. Thank you. Just to finish up with my next two slides. So our next steps, I would encourage you, having listened to the information today, to share innovation and different models with colleagues and to seek practical solutions and look at how potentially some of these could be scaled up. So we know that several services have presented today on very similar themes around optimizing care. There are opportunities to scale up potential innovations, so please do continue to share with each other. Don't assume that people know. Please share across services and even we can go wider and across regions as well. As we know, as new structures are forming across ICBs, so integrated care boards and regions, please promote opportunities for partnership working by engaging with all system partners, so between health and social care, voluntary sectors and all those involved, all those key partners. Again, seeking opportunities to come together to work on service models and pathways to support the 3 shifts and neighbourhood working, which are key priorities outlined in the 10-year healthcare plan. So thank you. Next slide, please. And to finish, I would like to thank all of our speakers today for sharing their insights. We'd also like to thank colleagues for joining us. And again, please do think about what you will take away from today's sessions and how you will contribute to lead and future innovation through partnership working. We would encourage you to join future webinars and to spread the word across your networks. If you'd like to give us some feedback on the sessions today, you'll see the QR code there. And if you have any suggestions for future webinars, please let us know. You'll receive a certificate of attendance on completion of the survey. So thank you again, and our next webinar session is on the 20th of April between 11 and 12, entitled Digital Education for AHPs. So once again, thank you all very much for coming today, and we look forward to seeing you in the future. Thank you.